What is up, guys? Welcome to Deep Learn Medicine, a place where we learn medicine actively. So, today the topic of our discussion is going to be renal tubular defects. So, the purpose of this video is not to be a 45-minute lecture where I'm going to go over every single low yield information, but instead, what I'm going to do is I'm going to provide you with a guiding framework that I created, which really helped me a lot. And I'm going to provide you with a cheat sheet in the end so that you can test drive it on question banks, your URL blocks, and provide me with the feedback if it helped you. So I'm going to explain each disorder to you, and then we're going to compare and contrast them so you can differentiate each disorder. I'll advise you to listen to me carefully without writing notes. At this time, you can write your notes when the video finishes and through your memory so that the process becomes more active and you're engaged. So let's get started. So let's begin by drawing out what we already know about the nephron. Here we have the glomerulus, and here we have the proximal convoluted tubule, and then we have the ascending limb, distal convoluted tubule, and then we have the cortical collecting system, right? So this is something that we already know. It's not hard, you already know this, right? Now, let's take it a step further. We know that the proximal convoluted tubule, what its job is to reabsorb amino acids, reabsorb glucose, phosphates, and bicarbonate, right? So now we know the function of proximal convoluted tubule. And what about the ascending limb? So the function of the ascending limb is, we know that we have a NK-CC transporter, sodium potassium 2-chloride transporter. So what we do here is we reabsorb sodium, potassium, and just erase this. We'll reabsorb sodium, potassium, and chloride, right? And let's move further. Next we have the distal convoluted tubule. We know that we have absorption of sodium chloride here along with calcium, right? And here's the sodium calcium transporter basically. And in the distal convolute and in the cortical collecting tubule, we have ENaC channels, and their function is to reabsorb sodium. Also, we've got aldosterone receptors, right? So this is not hard, right? So if you have trouble with this, I'd advise you to take your time and to really burn this into your memory. And also it's helpful to know where each of the diuretics work. For example, loops work here, and thiazides work here, and potassium-sparing diuretics work here. Okay, whatever. Okay, so what will happen in renal tubular defects? Well, as you can probably guess by the name, there would be defects in some or the other function of this nephron, right? And a commonality between the defects is that all of them will present with loss of potassium, which is also known as hypokalemia, right? And when you're going to look at the lab values and the pH, what you'll notice is most of them will have a rise in pH, which is also known as metabolic alkalosis, right? Except for one scenario, except for one of the renal tubular defects, all of them will have metabolic alkalosis, right? So what I'm trying to do here is I'm trying to create the similarities and differences so that when you come across a question in QBanks, you can easily recognize it. And I'm going to talk about the names later on after I create the entire paradigm. So you might be asking, why do these disorders present with metabolic alkalosis. So, how I try to think about these disorders is that whenever you have loss of water, since these disorders kind of work like diuretics and there's a lot of water that is lost through urine, what will happen is the loss of water will cause increase in aldosterone, which will eventually cause contraction alkalosis. Now, how does it cause contraction alkalosis? What aldosterone does is that it works on the proximal convoluted tubule and it reabsorbs a lot of sodium. And as you know, wherever sodium goes, water goes with it. So a lot of water is reabsorbed, and also in the collecting duct, bicarbonate is reabsorbed and hydrogen is excreted. So whenever bicarbonate is reabsorbed due to the effect of aldosterone, it causes alkalosis. Bicarbonate is alkali, so you can guess. Okay, now let's look at each part of the nephron and let's see the function that each of the part provides. So when we're talking about the proximal convoluted tubule, we can see that it reabsorbs most of the amino acids, it reabsorbs glucose and phosphates, and most importantly, it reabsorbs bicarbonate, right? So let's pretend that if for whatever reason the proximal convoluted tubule decides to not work today, right? What would happen hypothetically? Well, I could guess that amino acids would not be reabsorbed along with glucose and phosphates and bicarbonates, right? So let's try to use that to our advantage and come to think of the different presentations that this hypothetical disorder would have. Right. So, what we know is that whenever you lose a lot of glucose, water follows glucose as well, right? So, there would be a lot of volume depletion. This is how I like to think about it. That whenever you lose glucose in the nephron, water follows glucose and osmotically, and then you lose volume. What would happen when you lose phosphates? So, what are phosphates used for? Well, phosphates are used to create hydroxyapatite, which strengthens bone. Can you think of a disorder where the bones cannot be strengthened? If you're thinking about rickets and osteopenia, you're definitely right. Okay, so now we have a single presentation that this hypothetical disorder would have, that is rickets-like symptoms and volume depletion. What would happen if you cannot reabsorb bicarbonate in this instance? Well, if you cannot reabsorb bicarbonates, you would lose all of them in the urine, and ultimately the pH of the body would become more acidic, right? So, what do we call when we have an acidic pH? Well, it's called metabolic acidosis. So, like I mentioned before, there's when you look at the lab values, all of the renal tubular defects would present with metabolic alkalosis, except for this one, right? We have this disorder which would present with metabolic acidosis. So now I'm going to give this disorder a name. Let's just call this Fanconi syndrome, right? And if we want to talk about the different causes of this syndrome, then I think it really helps to think that all the renal tubular defects are caused by some genetic cause, right? So some are autosomal recessive and some are autosomal dominant. And in this case of Fanconi syndrome, we can come across Wilson disease as a probable cause, or tyrosinemia, or glycogen storage disease. Now you might be asking, how do they cause this? Well, how I like to think about it is, in Wilson disease, copper gets deposited into the PCT, and same is the case with glycogen. So all of that damages the proximal convoluted tubule. Ischemia can also damage the PCT because PCT has a lot of metabolic activity. So whenever there is ischemia, there's damage to the PCTs specifically, and I think that is the a major cause of acute tubular necrosis as well. And we also have multiple myeloma as a probable cause, in which the amyloid light chains are deposited in the proximal convoluted tubules. Different drugs or nephrotoxins can cause damage to this area of the nephron, and also lead poisoning. So, how I like to think about it is anything that causes damage to the PCT, be it any substance, that would lead to Fanconi syndrome, right? Okay, so now let's move on to the next region of the nephron, that is the ascending limb of the nephron. And I hope you know which ion channel is found here. And if you're thinking about sodium potassium 2 chloride transporter, you're definitely right. Can you think of a scenario where the sodium potassium 2 chloride transporter is not working? Well, it kind of sounds similar to how loop diuretics work, right? Loop diuretics work by blocking the NKCC. So if there was a hypothetical disorder that would damage the ascending limb, it would kind of present like loop diuretic use, right? So as we've already established that, except for Fanconi syndrome, all the renal tubular defects will have metabolic alkalosis. So the same is found in this case, and we'll also find hypokalemia, as in all the renal tubular defects. We'll also find hypocalcemia, and the cause of hypocalcemia is that whenever you block the NKCC channel, what happens is that there exists a electrochemical gradient between the ascending limb and the interstitium that is due to sodium, potassium, and chloride ion, the flow of these ions. And what happens normally is that this ion gradient assists calcium to get reabsorbed into the interstitium, and whenever you block NKCC channel, so this electrochemical gradient is basically abolished, and calcium is then excreted into the urine, which causes hypercalciuria. I don't think that's really high yield, but I'm just including that for completeness sake. Okay, so I will call this disorder Bartter syndrome, right? Okay, so now we're going to move on to the next portion of the nephron, which is called the distal convoluted tubule. And if you can guess what happens in this area is that sodium and chloride are reabsorbed, and a defect in this area entails that this reabsorption does not occur. And if you can think of a diuretic that works by a similar mechanism, then I think that you can correlate this disorder to that pretty well. That diuretics is thiazide, right? So whenever you're using thiazide, what happens is that you don't reabsorb sodium and chloride, and they get excreted into the urine, pulling along water. Also, another common feature of thiazide in this disorder is that they both cause increased reabsorption of calcium, right? So they increase the absorption of calcium, which causes a decrease in the amount of calcium left in the urine, right? So this disorder will present with hypocalciuria, and we'll also have the other findings that I already mentioned: metabolic alkalosis along with hypokalemia. What's specific in this case is the disorder will cause loss of magnesium as well. This is known as hypomagnesemia. I think you should really burn this into your memory. This is going to be really specific for this disorder. It's not found in any other renal tubular defect. So I'm going to name this disorder Gitelman syndrome. It's much less severe than the previous disorder, which was Bartter syndrome, and presents similar to thiazides. Okay, so the cause of this disorder is, as I mentioned with other disorders, is genetic, right? And later on, I'm gonna tell you how I think about the if it's autosomal recessive or if it's autosomal dominant. But let's just move on to the next portion of the nephron, and that is the collecting duct. So we know that the collecting duct has ENaC channels, and what these ENaC channels do is they reabsorb sodium, right? What would happen if hypothetically there is a disorder in which the ENaC channels become overactive? Well, as you can probably tell that whenever you reabsorb a lot of sodium, water comes with it. So you're going to create a volume overload state. And whenever there is a volume overload state, there is hypertension, right? And can you think about the levels of aldosterone in this disorder? How would they be affected? How I like to think about it is that whenever there's a volume overloaded state, the aldosterone is negatively affected. The body is basically telling aldosterone to stop working because the body already has a lot of volume in it, so there is no need for aldosterone to work. So the aldosterone levels in this disorder will basically be undetectable, right? And if you're thinking about the overactivity of sodium, how would you target this disorder? How would you treat it? Well, I would try to focus more on the activity of ENaC channels and try to stop it. Well, luckily, we have a drug that does the exact same thing, and that is amiloride, right? So, let's call this entire trouble that we have Liddle, even though it's not little, but we'll call this Liddle with a double D. Okay, so moving on. Let's try to think of another trouble that could occur in the collecting duct, which is the next segment of the nephron. What would happen if all of a sudden the aldosterone becomes over efficient and decides to work a lot on the collecting tubule? It becomes really overactive. Well, you could guess from the function of aldosterone that it would cause increased reabsorption of sodium, following which would be increased reabsorption of water, and a volume overloaded state that would cause hypertension. Moreover, what aldosterone would do is it would act on the collecting duct and it would reabsorb bicarbonate, causing the contraction alkalosis, as I already mentioned. Well, you're in luck because there is no such renal tubular defect in which the aldosterone is overactive. But why did I even mention aldosterone? Well, there is a similar renal tubular defect where there is a ton of cortisol. Now you might ask, how come cortisol is causing hypertension and contraction alkalosis? Well, cortisol acts just like aldosterone, and here the problem is not with the production of cortisol, but instead it's a problem of under excretion, or I should say, cortisol is not broken down by the enzyme, right? So what's this enzyme? Well, this enzyme is 11 beta HSD. 11 beta HSD degrades cortisol into its inactive cortisone state. Whenever 11 beta HSD is deficient, what will happen is that cortisol won't be degraded into cortisone, and the body will have a hypercortisol state. Now you might be thinking, what causes the deficiency of 11 beta HSD? Well, a very high yield cause of the deficiency of HSD is the use of licorice. Now, licorice is used for eczema and swelling of liver, mouth, and many other conditions. But the special ingredient in licorice is glycyrrhetanic acid. I'm sure I'm butchering the name, but this glycyrrhetanic acid is what causes the HSD, 11 beta HSD, to become deficient, which ultimately prevents the breakdown of cortisol. Another high yield cause of this disorder is the hereditary deficiency of 11 beta HSD. Now, this entire paradigm or this entire defect, I'll call this same as aldosterone axis. Great name, right? SAME. Well, the SAME stands for Syndrome of Apparent Mineralocorticoid Excess. Okay, so what would you expect the aldosterone levels to be in this case? Well, I know that aldosterone is not causing this trouble, and instead cortisol is. So, cortisol is causing this hypertension and volume overloaded state. Well, it might negatively feedback the aldosterone circuit, right? So, this is how your train of thought should be. Something is acting as aldosterone, so that would give negative feedback to aldosterone, presenting with hypertension. Let's just compare this with Liddle syndrome again. As we've already discussed, Liddle syndrome also presented with hypertension and decreased serum aldosterone, right? So this is something that you should keep in mind, that these two disorders are very similar, except one is caused by the overactivity of ENaC channels and the other is caused by high cortisol. Now, if you were a scientist and developing a drug for this treatment, how would you target this? Well, I would like to create a drug that would just block the mineralocorticoid receptors. Or I could give exogenous cortisol. What would that do? Well, exogenous cortisol would negatively feedback the production of cortisol, thereby breaking the vicious cycle, right? So, now we have all the defects, that is Fanconi, Bartter, Gitelman, Liddle, and same. A popular mnemonic to keep this disorder, all of these disorders in order, is Fanconi's bagels. The problem with PCT is Fanconi, ascending limb, Bartter, distal convoluted tubule, Gitelman, and collecting duct, Liddle syndrome, and same. Now that we have discussed the details of all of these disorders, let's pull out the cheat sheet. So whenever you come across a renal tubular defects question, you'll see the options and you will try to get an idea, and then there will be hypokalemia too in the question stem. The first question that I want you to ask yourself, how is the pH, right? Is there metabolic acidosis or is there metabolic alkalosis? If there is metabolic acidosis, it can't be any other thing than Fanconi syndrome, right? And to further confirm your suspicion, you're going to look at the phosphate levels, which will be low. Okay? Hypokalemia, renal tubular defect, along with metabolic acidosis, is always Fanconi. Moving on. If you see that there is metabolic alkalosis, right? Now I want you to see the calcium levels, right? Do you see the calcium levels, and if they are abnormal or not? If the calcium is abnormal, it could either be hypocalcemia or hypercalcemia, a rise in calcium or low calcium. If there's a rise in calcium along with decreased magnesium, it's Gitelman. Okay? And if there is decreased calcium, it is Bartter. Okay. The other disorder. So now you're going to check for hypertension, but low aldosterone, along with metabolic alkalosis. So you get a question, you see there's metabolic alkalosis, you see there's hypertension, but low aldosterone. Now I want you to suspect defect in the ENaC channel or increase in cortisol. The defect in ENaC channel would be Liddle syndrome, and the defect in or the increase in cortisol would be same. The question would also mention the use of licorice, if it's same, that is acquired, or they won't if it's hereditary. Okay. I also promise to tell you how to differentiate the hereditary causes. So a quick mnemonic that I use is that Liddle has a D, so it's autosomal dominant. The rest of them are autosomal recessive, except for Fanconi. Now, it's not really high yield to know the exact pedigree for Fanconi syndrome, but what you should know, which genetic disorders can predispose to Fanconi, and I already mentioned them, such as Wilson disease, glycogen storage disease, and tyrosinemia. Okay, so this ends our discussion for renal tubular defects. I hope you like this video, and I want you to use this cheat sheet, take it for a test drive, see how it helps you in your Q bank, and now you're allowed to write your notes. Like this video, subscribe to my channel, and I'll see you guys in the next one.